Hello guys, welcome back to the MedEd NExT YouTube channel. So I am Dr. Himanshu Gupta and I am radiology faculty here. So today we are going to discuss few important images that is important for your FMGE exam. So guys, I have divided this session into various systems. So we will be starting with the images from the CNS radiology, right? Then we are going to discuss images from the chest radiology. After that, we are going to discuss GIT and hepatobiliary images. And in the end, we are going to discuss few important images from the section of MSK. So I'm hoping that you are going to definitely like this session, right? And I'm going to try to cover most of the things that is important for your FMG exam. So let us wait for a few students to join and then we can begin the session.
Alpha, you are now approaching Mark 4.
Hello guys, so I am Dr. Himanshu Gupta and I am your radiology faculty at PW MedEd. So today we are going to discuss important images from the radiology section, and I hope these images will be helpful for you for your FMG exam, and I'm sure that you will be able to answer most of the questions if you just have a careful look at the images that I'm going to show you in the next 1.5 hours. So guys, let us begin. Let us begin with the CNS radiology, right? So in CNS radiology, the first basic thing that we need to know is that how to differentiate between a CT image and a MRI image. So let us start with the basics. So guys, if I look at the NCCT head images, the thing I need to see in the NCCT head is the bone. If I am able to see the bone which is appearing white on the NCCT head, then it is a NCCT head. But if the image, the bone does not appear white, it is appearing black, then I'm going to think of an MRI image. So this is one way to differentiate between an MRI image and a CT image. Then guys, we should know how to, what are the important uses of NCCT head? Which are the conditions in which I'm going to prefer NCCT head? The first and the most important condition is that of trauma. So if a patient comes to emergency with history of head trauma, you are going to get an NCCT head done to rule out an intraaxial bleed, right? Then MRI. Okay, MRI is the investigation of choice in patients with brain tumors. In brain tumors, any demyelinating disorder like multiple sclerosis and even acute infarct, the imaging investigation of choice for acute infarct will be an MRI brain, right? So let us have a look at the different sequences of the MRI brain. So beginning with the first sequence that I am seeing here is the T1 vivid image. So how do you say that this is a T1 vivid image? Guys, if you look at the white matter on this image, so this white matter, it is appearing white. This white matter is appearing white. And if you look at the gray matter, it is appearing dark. So when the white matter is white and the gray matter is dark, then you are going to think of a T1 weighted image. Now if I talk about the second image, guys, if I talk about the second image, in the second image what I can see is that white matter is dark as compared to the gray matter. So white matter is dark as compared to the gray matter. That is why this image is a T2 weighted image. So guys, can you tell me what are the other things? What are the other things that is going to tell me that this is a T2 weighted image? Anyone in the comment section, guys? Anyone in the comment section who can tell me that this is a T2 weighted image? So guys, we have to look at the CSF. We have to look at the CSF. If the CSF is bright, then that image is a T2 weighted image if the CSF is bright. So here in this image, if we look at the subarachnoid spaces, so in these subarachnoid spaces, we can see that the CSF is appearing bright. So that is why this image is a T2 weighted image. Now coming to the third image. So in this image we can see, if you just look at the white matter, so in both these images the white matter is dark, and gray matter is gray, right? But if you look at the CSF spaces, this is the CSF space that you need to look at, and in this CSF space we can see that the CSF is appearing dark. So because the CSF is dark in this image, so guys, this is a fluid attenuation inversion recovery sequence. This is a FLAIR image, right? And FLAIR image is used to have a look at the edema, right? So and coming to the last image, guys. So in this image we can see that there are ring enhancing lesions can be seen in the left frontal lobe. Ring enhancing lesions can be seen in the left frontal lobe, and we can also see that there is enhancement of the dural sinuses. So guys, this is a post contrast image. So generally post contrast image is used in patients with infection, in patients with trauma, right? So now let us begin with other sequences that we need to know, right? So the image B that you are able to see here, this is a diffusion weighted image, and diffusion weighted image, guys, we all know that this is used in a patient with acute infarct. So acute infarct appears bright on the diffusion weighted images, So here in this image we can see that this is a diffusion weighted image, and there is a hyperintensity involving the right frontal lobe, occipital lobe, right, and even the basal ganglia. And if I look at the corresponding ADC maps, on the ADC maps, this image is appearing dark. The same area is appearing dark. So guys, this is a rule for any lesion or area showing diffusion restriction. So for an area to be called as restricted diffusion, it has to appear bright on the DW images and dark on the corresponding ADC maps. So this is a rule that needs to be followed. So here in this image we can see that there is an area which is appearing bright on DWI and dark on the ADC maps, and it is following the MCA territory. So this is most likely a case of MCA infarct. And the last image, guys, in the last image what we are able to see, that there are black dots. So these are nothing, these are foci of blooming, which is seen on SWI images. And these SW images or susceptibility weighted images, whenever there is a focus of calcification, whenever there is a focus of hemorrhage on the SWI images, it is going to appear as black dots, right? So this sequence, this is useful in a patient with diffuse axonal injury, right? Now let us move to the imaging features of stroke. So guys, I want to hear from you. How many of you are listening to me? Hi Nitish. So I just want to hear from you guys. I want to know from you which all colleges you are listening to me, right? Then we are going to discuss the imaging features of hyperacute ischemic stroke. So if I ask you, what is the investigation of choice in a patient with hyperacute ischemic stroke? What is hyperacute ischemic stroke? It is any stroke that is less than 6 hours, right? So in a stroke which is less than 6 hours, hello Akash, a stroke which is less than 6 hours, guys, in that case, what is going to happen? your NCCT head can be completely normal. That is why investigation of choice is MRI. And within the MRI, you are going to see diffusion weighted images, which is going to appear as bright area on diffusion weighted images, right? So now talking about hyperacute ischemic stroke. So what happens? This stroke occurs due to formation of a thrombus within the arteries. So this thrombus can form within the middle cerebral artery, it can form within the basilar artery, right? And that thrombus is going to appear hyperdense. That thrombus is going to appear hyperdense on NCCT head images, right? Now this thrombus will be seen on the NCCT head images in a patient with hyperacute ischemic stroke, right? So if it is seen in the region of basilar artery, it is known as dense basilar artery sign, right? When it is seen in the region of MCA, it is known as dense MCA sign. And if it is seen in the region of Sylvian fissure, it is known as Sylvian dot sign. It is known as Sylvian dot sign, right? Sometimes what happens, you can see that there is a hypodensity in the region of insular cortex, right? Normally what happens, there is differentiation between cortex and the white matter in the region of insula. So when there is blurring of the gray white matter differentiation in the region of insula, that is known as loss of insular ribbon sign. Loss of insular ribbon sign. And in the last image, guys, in the last image, if you just look at this image very carefully, guys, what you can see on the right side, we can see that there is hyperdense basal ganglia which can be seen. This is the lentiform nucleus, this is the caudate nucleus. But on the left side, guys, if you look at this image very carefully, you are not able to see the basal ganglia. So this is known as disappearing basal ganglia sign in a patient with hyperacute ischemic stroke. Coming to acute ischemic stroke, this is the stroke that is there between 6 hours to 1 week. What happens in this stroke? This appears as an area of hypodensity. Wedge-shaped area of hypodensity can be seen. So this is the wedge-shaped area of hypodensity, and there is loss of gray white matter differentiation. Loss of gray white matter differentiation can be seen. So if you are able to see these three features, hypodensity, loss of gray white matter differentiation, and the time is between 6 hours to 1 week, then you are going to think of acute ischemic stroke. And in a subacute infarct, it lies between 1 week to 3 weeks. And there is one phenomenon that you can see in subacute infarct, that is known as CT fogging phenomenon. And what happens in CT fogging phenomenon? Within the area of hypodensity, there is hemorrhages which is taking place within the area of infarct. And because of this area of hemorrhages, what happens? So this hypodense area, it starts appearing hyperdense. This hypodense area starts appearing hyperdense, and it looks like a normal brain. So basically, the area of hypodensity is not very well visualized. The area of hypodensity is not very well visualized, and this is known as CT fogging phenomenon. And in chronic infarct, what happens? In chronic infarct, the area, okay, if you look at this area, this chronic infarct, it looks like your CSF. So this is the CSF in the ventricle, and this is the chronic infarct. So you can see that chronic infarct will look more like your CSF because of the death of the normal brain tissue. Now, another question that can be asked in the form of an MCQ is that what are the most common locations for the lacunar infarct? So these are the most common location. You have the basal ganglia, internal capsule, corona radiata, and pons. And in this image, you can see that there is an area of hypodensity in the region of left thalamus. Area of hypodensity can be seen in the region of left thalamus, and this area of hypodensity is less than 2 centimeter in size, and that is why this is known as lacunar infarct. Most common locations: basal ganglia, internal capsule, corona radiata, and brain stem. So what is this investigation that is being shown to us? Would anyone like to answer what is the investigation that is being shown to us in this image? Anyone, guys? What is the investigation that is being shown to us in this image? So guys, the investigation that is being shown to us in this image, this is a digital subtraction angiography image, right? And what is the appearance of this image? What is the appearance of this image? This is the puff of smoke appearance, and this puff of smoke appearance, this is seen in a patient with Moya disease. And in Moya disease, what happens? There is narrowing of the clinoid and the supraclinoid segment of IC, and because of the narrowing of the internal carotid artery, multiple collaterals are forming, and these collaterals give the shape of the puff of smoke that is seen on digital subtraction angiography images, right? So this is Moya, right? Moya disease, right? So if you are not able to identify this thing, Moya disease, in the exam, what will happen to you, right? Moye हो जाएगा आपके साथ एग्जाम में. So be careful that you are able to identify. Now let us see how you are able to identify a bleed on the NCCT head. How to identify a bleed on the NCCT head images. Any bleed on the NCCT head images, guys, it is going to appear bright, right? It is going to appear bright. So here in this image, we can see in the first image, there is a hyperdense area that you are able to see. So this hyperdense area is an area of the bleed. Now this area, this concave shaped area, is another area of bleed, and hyperdensities within the brain can also be seen, right? So very good Sammy, very good Sammy. So in the first image, if we look at the first image, this is a biconvex shaped bleed, and this is your extradural hemorrhage. Why? Because it is biconvex. It is a, if it is a concavo-convex shaped bleed, it is subdural hemorrhage, and it is due to the rupture of cortical bridging veins. Whereas extradural hemorrhage, it is due to the rupture of middle meningeal artery, and you are going to see lucid interval in these patients. Lucid interval will be present in the history of extradural hemorrhage. And if I talk about the last third case, so in this third case, what we are able to see, multiple hyperdensities can be seen within the right frontal lobe. So this is nothing, this is but your hemorrhagic contusions. So this hemorrhagic contusions, this is seen in patients with trauma, right? And what is the differentiating feature of hemorrhagic contusions is that they are surrounded by an area of edema, an area of hypodensity. Because they are surrounded by an area of hypodensity, this is an intraaxial bleed, that is your hemorrhagic contusion, right? Now let us see one more type of bleed, right? What are we able to see, guys? What are we able to see? Come on, tell me what are we able to see? We are seeing hyperdensities along the basal cisterns. So this hyperintensity is nothing, this is The bleed which is present along the basal systems, this is the suprasellar system, this is the sylvian fissure, this is the ambient system, and hyperdensities can be seen. So this is your case of subarachnoid hemorrhage. And guys, can you tell me what is the cause of subarachnoid hemorrhage? What is the cause of subarachnoid hemorrhage? So the cause is, most common cause is rupture of perianeurysm. Rupture of perianeurysm. Very good semi-zone, right? So we all know that your intracranial vessels, that is your ACA, MCA, IPCA, they are lying within the basal systems, they are lying in the subarachnoid spaces, and whenever there is hemorrhage, whenever there is aneurysm of these arteries, and they rupture, it results in hemorrhage within the subarachnoid spaces, right? So I will just try to give you the clinical history behind this image. So the patient has history of trauma, right? The patient is an altered sensorium, and NCCT head was absolutely normal in this patient. Then after that, what happens? An MRI brain was done for this patient, and within the MRI brain we can see that there are foci of blooming black dot. It means that there are few hemorrhages, and they are predominantly seen at the gray white matter junction. So guys, what is your diagnosis for this case? So diagnosis is diffuse axonal injury. So if you have characteristic these three features, that is trauma, altered sensorium, and NCCT head is normal, what you are going to think of diffuse axonal injury. And what you will see on the SWI images, foci of blooming predominantly at the gray white matter differentiation. Very simple question, most common site of hypertensive bleed that is asked again and again in your MCQs, and it is putamen, right? Putamen is the most common site. Now what are we able to see on this image? So this is the bone window images of the NCCT head, and this is the normal soft tissue or brain window images. And on these brain window images we can see that there is some black area that is seen in the frontal lobes, and guys, what is this black area in the frontal lobes? Anyone? Dr. Suwadi, would you like to comment what is this black area? There are two things which appear black on CT. One is fat and the other is air. These are the two things. So fat is unlikely in this area, so this is air, the air which is present within the extraaxial spaces of the bilateral frontal lobes. So guys, this air is coming due to the fracture of the frontal bone, right? And because of the fracture, air has entered the extraaxial spaces, and this is known as pneumocephalus. Name of the sign is Mount Fuji sign. Midline cystic swelling, hydrocephalus, and congestive heart failures, right? These are the clinical features which have been given to us in the question. Now the answer is, what is the diagnosis? Question is, what is the diagnosis? An MRI brain image is also given to us. We can see that there is a large flowlet that can be seen in the midline, right, in the region of straight sinus or vein of Galen. So this is nothing, this is your vein of Galen malformation. What happens? There is arteriovenous fistula formation within the vein of Galen, and because of this arteriovenous fistula formation, this vein of Galen gets dilated, and this dilated vein of Galen appears as a midline cystic swelling on the ultrasound images, right? And it results in compression of the third ventricle or the aqueduct of Sylvius, because of which it results in hydrocephalus, and because of the arteriovenous fistula, more blood is reaching the heart. It results in congestive heart failure. Right? Now these are another important signs seen and commonly asked in the MCQs. So the second is the Dawson's fingers. So these are flare images, and on the flare images we can see that there are finger shaped perpendicular hyperintensities within the white matter. And here in this images we can see that there is hyperintensity in the form of dot and dash within the roof of the lateral ventricle. So this Dawson's fingers and dot and dash sign is seen. Dawson's fingers and dot and dash sign is seen in a patient with multiple sclerosis. Multiple sclerosis. Right? Is that clear? Now, talking about few leukodystrophies. So, leukodystrophies is another favorite question of the examiners as far as radiology is concerned. So, let us take a look at the leukodystrophies. So, if this thank you, Dr. Suvadeep. So, so guys, let us look at these leukodystrophies. So guys, let me tell you, if ever there is a hyperintensity in the white matter on the T2 variant images, it is abnormal. It is abnormal. So here what is happening? Here we can see that white areas can be seen within the white matter on the flare or T2 variant images. So this is abnormal white matter, or these are abnormal these are your demyelinating diseases, right? So here we can see we have to identify the leukodystrophies. So if a leukodystrophy is giving this tigroid pattern, it is giving a tigroid pattern. So this tigroid pattern of leukodystrophy, come on guys, Subhadeep, can you tell me what is this tigroid pattern of leukodystrophy is seen in patient with anyone? Metachromatic leukodystrophy, right? Metachromatic leukodystrophy. Now if you see in this third image, so you have to see that this hyperintensity is seen predominantly in the frontal lobe. When this hyperintensity is present predominantly in the frontal lobe, this is a case of Alexander disease. Hyperintensity predominantly in the frontal lobe is your Alexander disease, right? Then in the last image, guys, we can see in the last image there is parieto-occipital predominance, and this parieto-occipital predominance is seen in X-linked adrenoleukodystrophy. Is that right? Now in the first image we can see that there is hyperintensity seen in bilateral cerebral hemispheres, but it is also involving the subcortical U fibers. It is also involving the subcortical U fibers. And when this happens, guys, this is a case of Canavan's disease. Right? So I hope all the leukodystrophies are clear to you. Now talking about few infections. So this is another question which is asked. So whenever you see that there is a patient with ring enhancing lesions, right, then basal exudates, it comes in the form of MCQ only. Basal exudates, ring enhancing lesions, and hydrocephalus. So guys, what is the diagnosis that you are going to think of? You are going to think of tubercular meningitis. Now, multiple cystic lesions within the brain can be seen on the T2 vivid images. And if you look at these images, cystic lesions, you can also see that there is an eccentric scolex. Eccentric scolex can be seen within these cystic images. So, cystic lesion with an eccentric scolex or an eccentric dot, you are going to think of neurocysticercosis. Now, within the neurocysticercosis, an important question that comes is edema is seen in which stages of neurocysticercosis? So, edema will be seen in a patient with colloid vesicular stage and granular stage. No edema will be seen within the vesicular stage and the calcified stage, right? Now another very important, very good Subhadeep. So this is periventricular calcification. Periventricular calcification is seen in patients with cytomegalovirus infection. Just remember this condition and this NCCT head. So these are the ventricles, and within this ventricles, this is the hyperdensity which can be seen along the walls of the ventricle, and this hyperdensity is nothing, this is just your calcification. And also if you can look at the Sylvian fissure, the Sylvian fissure also appears prominent. Another very important MCQ that is asked. So what is this? This is eye of face of giant panda. Face of giant panda. So this is seen in a patient with Wilson's disease. Right? So you have to tell me in the comment section what is the mutation that you are going to see. What is the mutation that you are going to see in these patients? So mutation is and what happens, there is deposition of copper deposition in the eyes results in the Kayser-Fleischer rings. And within the brain you can see within the midbrain there is hyperintensity, and this hyperintensity is involving the tegmentum of midbrain and it is sparing your red nucleus, and because of this it gives a face of giant panda sign. Now another very important named signs as far as CNS radiology is concerned. So this is the molar tooth appearance seen in Joubert syndrome. Then you have the stigroid appearance of the cerebellum, right? It is seen in Lermite Duclos syndrome. And then you have the eye of tiger sign. That is seen in Hallo-Warden's disease, right? So a patient presents with abnormal eye movements and decreased cognition. What are we able to see? We are able to see that there is hummingbird sign seen within the midbrain, right? And this hummingbird sign is seen in progressive supranuclear palsy. On the axial images it is going to have a Mickey Mouse sign. This is your progressive supranuclear palsy. Let us talk about few important imaging features of brain tumors, right? And few important MCQs that are asked within the brain tumors. So most common brain tumor is, no doubt in that, it is your metastasis. Most common primary brain tumor, it is meningioma. Most common intraparenchymal brain tumor is glioma. Most common intracranial tumor to calcify, this is your oligodendroglioma, right? So here again what we can do, we need to know that the brain tumors can be of two types. They can be intraaxial or they can be extraaxial. So intraaxial means that the brain tumor is present within the brain. Extraaxial means that brain tumor is present outside the brain tissue. For example, meningioma. So meningioma is an extraaxial lesion, meaning it is not arising from the brain tissue. And what is the important feature of extraaxial brain tumor is that it is surrounded by CSF on all sides, and you can also see flowwards. So it is surrounded by CSF on all sides, and it is flowwards are also seen. So this sign is known as CSF vascular cleft sign. So this is one of the signs that is seen in meningioma. Other signs that are seen within the meningioma, you should also know that is your dural tail sign. You have mother-in-law sign, right? These are important signs again which are seen within a patient with meningioma. Now another very important image that is important for you to remember. So these are the post contrast images, and on these post contrast images we can see that there is a cyst, and within the cyst there is an enhancing solid component. So this is cyst with a mural nodule tumor, and we have to know what are the important differential diagnosis for this case. This includes pilocytic astrocytoma seen in children and in the uh, cerebellar hemispheres. Hemangioblastoma, another important differential which you should remember. Third is ganglioglioma, and fourth is pilocytic pleomorphic xanthoastrocytoma. So these are the four important differentials that you should remember for a tumor with a cyst with a mural nodule. Right, so just remember, hemangioblastoma will be seen in the supratentorial compartment. Pilocytic astrocytoma will be seen within the cerebellar hemispheres. And talking about ganglioglioma and your PXA, these are both cortical based lesions, cortical based tumors. So basically they will be found within the cortex of the brain. Now talking about important, very important. Okay, so the named signs in the brain tumors which you cannot leave for preparing for any competitive exam. So can you tell me what are the named signs first? What I am showing you in the first image. In the first image we can see that there is bracket shaped calcification. In the second image we can see that there is an ice cream cone shaped tumor, and in the third image I can see that there is a butterfly shaped tumor, and in the last image we have a snowman shaped appearance of the tumor. So come on guys, very simple question. So all these tumors, these are seen in, the first is seen in corpus callosum lipoma. Corpus callosum lipoma, ice cream cone appearance. Ice cream cone appearance, this is seen in a patient with vestibular schwannoma. And remember that multiple inherited schwannomas, these are seen in patients with neurofibromatosis 2. Butterfly tumor is seen in glioblastoma due to the involvement of the corpus callosum, and snowman appearance or figure of 8 appearance is seen in pituitary macroadenoma. Right, now here let us see one more important case. So here in this case we can see that there is tram track shaped calcification and there is discoloration of the face, right, in the region of maxillary nerve distribution. So this is nothing, this is your Sturge-Weber syndrome. And in this Sturge-Weber syndrome, if you just look at the brain very carefully, within the brain you can see that there is atrophy of only one cerebral hemisphere. The other cerebral hemisphere is completely normal, whereas in the right cerebral hemispheres you can see that the sulcal spaces are prominent, even the ventricles are prominent. This is because of the atrophy of the right cerebral hemisphere, right? So this is a case of Sturge-Weber syndrome, right? And in the second image, okay, what we can see, multiple calcified nodules can be seen along the ventricles. So this multiple calcified nodules along the ventricles, these are your subependymal nodules, right? And there is one another avidly enhancing lesion arising from the frontal horn, and this is a case of subependymal giant cell astrocytoma. So all these are imaging features of tuberous sclerosis. So guys, if I talk about tuberous sclerosis, you guys should also be aware of the tumors of the tuberous sclerosis that you can see within the abdomen, within the heart, right? You should be aware about that. Now let us talk about few important images from the section of chest radiology, right? So the most important sign as far as x-rays chest is concerned, so that is the air bronchogram sign. And this air bronchogram sign, this is seen in a patient with any consolidation within the lung. So what happens within a consolidation is that there is an area of homogeneous opacity, and along with that homogeneous opacity we can also see that bronchioles are running through that homogeneous opacity. So here in this x-ray we can see that there is a patchy air space opacity, and within this opacity we can also see that there is linear translucencies can be seen. So here again these are the CT images, homogeneous opacity with linear translucencies. So this is a case of consolidation. And what is the name of the sign? No, this is not ABPA. In ABPA we are going to see central bronchiectasis. So that is also we are going to see, right? So another very common infection in India, that is tuberculosis. So what are the important signs in tuberculosis as far as radiology is concerned? So on the NCCT chest images we are going to see tree in bud appearance of the nodules. Tree in bud appearance of nodules can be seen. And if I look at the CECT chest images, on the CECT chest you will see that multiple necrotic mediastinal lymph nodes can be seen. So these are the two most important features as far as tuberculosis is concerned, right? And you can have other patterns also. You can see the formation of cavities. These are your cavities formation that can be seen within the secondary tuberculosis. You can also see the nodules, right? Yes, this is the parenchymal lesion, Gons focus. So when the lesion is present within the lung, it is a Gons focus. When it is present within the lymph nodes, it is a Gons complex. And when there is calcification of the Gons complex, it is known as Ranke complex, right? So when the nodules are scattered in both the lung parenchyma, nodules are scattered randomly in both the lung parenchyma, that is miliary pattern of tuberculosis, right? So sometimes what happens, there is formation of aneurysm, okay, formation of aneurysm within the branches of the pulmonary artery, and this is known as RAS Mucin aneurysm. And what is the clinical feature? That is, the patient is going to present with massive hemoptysis. Now let us have a look at few fungal infections, right? So in the first image, what we are going to see, this is the monod sign, which is seen in the fungal ball or aspergilloma. In the second case, what we are seeing that the patient has history of asthma, and now the patient has come with breathlessness. We do an NCCT test for this patient, and we can see that there is central bronchiectasis. So this central bronchiectasis, this is again, and on the chest x-ray we have a finger in glove appearance. So guys, these are important features of allergic bronchopulmonary aspergillosis. And there is one more sign that we need to know, that is the halo sign. So halo sign is seen in angioinvasive aspergillosis, in which you are going to see a homogeneous opacity, and that homogeneous opacity is surrounded by ground glass opacities. So this is a sign of angioinvasive. So reverse halo sign, you have to tell me in the comment sections. Reverse halo sign is seen in. Coming to important signs of collapse, named signs of collapse. ठीक है, that is also asked, right? So if there is a homogeneous opacity in the left lower zone, collapse of the left lower lobe, this is your flat waist sign. So you can see a homogeneous opacity that is seen in the retrocardiac area, and retrocardiac area, just remember, it is one of the hidden areas of the lung, and if the homogeneous opacity is seen in the left upper zone, and we can also see that there is an area of lucency around the arch of aorta. Area of lucency can be seen around the arch of aorta. So this is an arc shaped radiopacity, and this is known as Luft sign, and this Luft means air and Sichel means sickle shape. This Luft sign, this is seen in a patient with left upper lobe collapse. And in the third image, homogeneous opacity is seen in the right upper zone, and it is taking the, if you can see, the lower border is taking the shape of the S. So that is why this is known as golden S sign of right upper collapse. And homogeneous opacity is resulting in loss of silhouette of the right heart border is your silhouette sign, right middle lobe collapse. Is that clear? Important named signs of collapse, right? These are very frequently asked. Very good, Subhadeep, you have to tell me one more case in which you are going to see the reverse halo sign. That is again very important. So now guys, we have to know homogeneous opacities. Okay, so opaque hemithorax, we should know how to differentiate between two opaque hemithorax. So in both these x-rays A and B, there is a homogeneous opacity in the left lung. So guys, can you tell me, are these both x-rays same or not? Tell me in the comment section, are these x-rays same or not? And if they are different, how can we look at these x-rays and we can say that these x-rays are different? How can we have a look at these x-rays and say that these x-rays are different? Anyone? Come on guys, come on. How can we say that these x-rays are different? So guys, if I look at these x-rays, in the first x-ray, if you can see the trachea is deviated to the opposite side, and in the second x-ray we can see that trachea is deviated to the same side, right? No, Subhadeep. Reverse halo sign is seen in one more case. Just read about it, right? And mention it in the comment section. So in the first x-ray we can see that trachea is deviated to the opposite side, and in the second x-ray we can see that trachea is deviated to the same side. So the first x-ray is due to the pleural effusion. A fusion will push the trachea to the opposite side, and the second x-ray is due to the collapse of the left lung, and you will see that trachea will be pulled towards the same side, right? So guys, this question was asked in the recent NEET PG exam, right? And in the AIMS exam also this was asked. They are asking you to identify the posterior ribs. So let us learn today how to identify the ribs, right? So if I look at this x-ray, okay, this rib is the first rib, this is the second rib, right? So you have to see, I'm going to label the anterior ribs, 1, 2, this is the third rib, this is the third rib, right? This is the third rib, this is the fourth rib, right? So you should know how to count the ribs. So if I'm looking at this area, you can see that there is a fracture involving this rib. Now the question will be asked, so the fracture is seen involving which ribs? So here comes the importance of how to identify the ribs. So let us try to identify. This is the first rib, this is the second, this is the third, and this one is the fourth rib. So here in this image we can see that there is a fracture involving the fourth and the fifth rib. Fracture involving the fourth and the fifth rib, right? Very good, very good, very good semi zone. Okay, so अगर एंटीरियरली फ्रैक्चर दिख रहा है तो एंटीरियरली काउंट करें रिब्स को, अगर पोस्टीरियरली दिख रहा है तो पोस्टीरियरली स्टार्ट करें, 1 2 3 4 5 6 7 8 9 10, right? So this is a very common question that is again and asked in many exams, right? So here in this chest x-ray, what we are able to see in this chest x-ray, we can see that there is calcification seen in the perihilar region, and on the gallium scan, what we can see that there is a panda sign. So perihilar calcification, that is your calcified lymph nodes, hilar lymphadenopathy, and increased uptake in the lacrimal and parotid glands. These are important features of sarcoidosis, right? Now a patient comes with chest pain, breathlessness. What are you able to see? You see that the heart size is enlarged. Then you can see that there is capitalization of vessels, upper lobe vessels, right? And you can also see perihilar opacities. So these are bat wing shaped opacities. These are important features of patients with congestive heart failure. And also you can see that there are lines which are perpendicular to the pleura. These are your curly B lines which can be seen. Curly B lines can be seen in these patients, right? Important features of congestive heart failure. So let me tell you, curly B lines will be seen along the pleura. Curly A lines will be seen along the hyla. Okay, along the hyla, right? So they will be seen along the hyla, right? And talking about curly D lines will be seen on the lateral radiograph just behind the sternum, They are nothing, they are just your curly B lines on the lateral radiograph. And all other lines which are seen, they are nothing, they are but your curly C lines. Then talking about this X-ray, guys, on this X-ray, we can see that there is an area of lucency. The patient comes with breathlessness, right? What are you able to see? Come on, guys. On this X-ray, we can see that there is an area of lucency in the right chest, right? And if this area of lucency, we can see that it is devoid of any lung markings. And we can also see that there is a line which is known as visceral pleural line, which can be seen on this X-ray. So guys, this visceral pleural line, area of lucency, okay, all these are imaging features of an important condition, that is pneumothorax. Now this pneumothorax, this can be clubbed with a surgical question also. Okay, what is the treatment? Okay, where you are going to insert the needle, which intercostal space you are going to insert the needle, right? And they are going to show you an X-ray. So direct question on imaging may not be asked. So this is the pneumothorax. Another important sign that you see in pneumothorax is the deep sulcus sign that you can see in patients with pneumothorax because of the collection of air along the costophrenic space. Now let us have a look at the lung imaging findings. Okay, so on the normal, in a normal lung, what happens? Okay, we are going to get this seashore sign. So this is seen on the M mode ultrasound, and we can see that there are multiple dots can be seen, and these are the waves of the sea which gives this appearance, the seashore sign, right? Whereas what happens in a patient with pneumothorax, you will see multiple parallel lines giving the appearance of barcode. So this barcode sign will be seen in a patient with pneumothorax, will be seen, right? Barcode sign and seashore sign. Now let us have few important signs of the pneumomediastinum, again a medical emergency, right? So what happens whenever there is collection of air in the pneumomediastinum? It is going to outline the structures of the mediastinum. So when it is going to outline the bronchial arteries, okay, it is going to outline the great vessels, it is going to outline the thymus, right? So this is known as Penneker sign when it outlines the thymus. When the diaphragm becomes continuous, this is known as continuous diaphragm sign. And these are the important signs of the pneumomediastinum. Okay. Another important thing that we should know important signs of the chamber enlargement. Okay. So सबसे important is right atrial enlargement, right? So when the right heart border is more than 2.5 centimeter away from the lateral margin of the vertebra, right? This is seen in a patient with right atrial enlargement. ठीक है, जल्दी जल्दी से बताता हूँ. इन द लेफ्ट वेंट्रिकल एनलार्जमेंट what is going to happen, the apex of the heart, it is going to shift downwards and laterally. When this apex of the heart it is shifted upwards, and this is seen in patients with right ventricular enlargement, and example is tetralogy of Fallot, right? So these are important signs of chamber enlargement. ठीक है. Pericardial effusion, you are going to have this Oreo-Cookie sign of pericardial effusion. Now talking about congenital heart diseases. First investigation of choice in patients with congenital heart diseases is echocardiography, right? Investigation of choice, right? Sorry, first investigation can be chest x-ray, and investigation of choice is echo. And for preoperative imaging you can get a CT done. So again, very important images as far as your FMGE exam or NEET PG exam is concerned. Okay, you cannot skip these images. So first is snowman appearance. So the first is, this is seen in patients with total anomalous pulmonary venous connection, when all the pulmonary veins they are draining into the, normally the pulmonary veins drain into the left atrium. So when they drain into the right atrium or SVC or IVC, this is known as TAPVC, giving the snowman appearance. And in the second image we can see that this is egg on string appearance, that is seen in patients with transposition of great arteries. And in the third image we can see boot shaped heart, which is seen in patients with tetralogy of Fallot. And what are the features that you are going to see in tetralogy of Fallot? You are going to see pulmonary stenosis, ventricular septal defect, overriding of aorta, and you are going to see a right ventricular hypertrophy. And the last image is box shaped heart, that is associated with lithium use in pregnant females, and this is seen in patients with Epstein anomaly. Right? So few important points about lung tumors, right? If a lung tumor, it is not associated with smoking, okay, it is more common in women, you are going to think of adenocarcinoma, right? Lung tumor associated with smoking, right, centrally located, you are going to think of squamous cell carcinoma of lung. A lung tumor which is associated with paraneoplastic syndrome, SVC syndrome, right? It is going to involve your superior vena cava. Then you are going to think of small cell carcinoma of lung. Both these tumors are associated with smoking, right? A benign tumor of the lung associated with calcification, this will be seen in pulmonary hematoma, right? Right? So this was all about cannonball mets. Again, very important tumor. Cannonball mets are seen in patients with renal cell carcinoma, endometrial carcinoma, okay, then choriocarcinoma. These are important examples you should remember as far as cannonball. So these cannonball mets are multiple round metastasis which are seen in both lung parenchyma. right? So guys, I hope that you like the important images from the section of CNS as well as chest radiology. Now we are going to revise important barium spotters that can be asked in your FMG एग्जाम. ठीक है, तो शुरू करें. So guys, let us try to answer these questions. Okay, so these are images 1, 2, 3 and 4, right? So in the first image we can see that there is a linear filling defect within the esophagus. This is seen in a patient with esophageal web. You should know that esophageal webs are seen in patients with Plummer-Vinson syndrome. It is associated with iron deficiency anemia and dysphagia. Here we can see that there is distal smooth tapering of the esophagus, and this is seen in a patient with stricture, right, due to caustic injection, right? Third image, we can see that there is a diverticulum arising from the posterior aspect of the esophagus. Patient will complain of halitosis, and this is your Zenker's diverticulum. And in the fourth image we can see that there is a diverticulum. No Subhadip, this is not CA esophagus, this is stricture, right? This is a stricture involving the esophagus, long segment stricture of the esophagus. And in the fourth image we can see that there is a diverticulum which is arising from the lateral aspect of the esophagus. So this is Killian-Jamieson diverticulum. Killian-Jamieson's diverticulum, right? So coming on to other barium swallow images. So here we can see that this is the corkscrew esophagus. The patient complains of chest pain, and this corkscrew esophagus is seen in patients with diffuse esophageal spasm. Worm-like filling defects within the esophagus. This is seen in patients with esophageal varices. And in the third image we can see that there are transverse bands within the esophagus can be seen, transverse bands, and this transverse band is seen in feline esophagus. Okay, and it can be associated with gastroesophageal reflux disease, or it can be seen in patients with eosinophilic esophagitis. Eosinophilic esophagitis, right? Now coming on to the other images. So this is the first one, is the bird's beak appearance. Bird's beak appearance is seen in patient with eclasia cardia, and this is the rat tail appearance. Okay, sorry, this is the rat tail appearance which can be seen in patient with esophageal cancer. So this is the esophageal cancer, right? एकदम से नैर्विंग हो रही है, इरेगुलर नैर्विंग है, वो बड़ी स्मूथ नैर्विंग थी. Okay, so Subhadeep, if you just compare these two barium swallow images, बड़ी स्मूथ नैर्विंग है, ठीक है, स्मूथ नर्विंग है. और इस वाली कंडीशन में इस वाली कंडीशन में यू कैन सी दैट इफ यू जस्ट हैव अ लुक एट द म्यूकोजा, बड़ी इरेगुलर सी है, ऐसे स्मूथ नहीं है, ठीक है. तो वो स्ट्रक्चर में मिलेगा, ये आपको मिलेगा इसोफेजियल कैंसर में, राइट. So this is a patient who had difficulty in breastfeeding. After breastfeeding, there was frothing from the mouth, right? Frothing from the mouth, and NG tube was inserted through the mouth, and you can see what is happening to the NG tube. So you can see that there is coiling of the NG tube, which is seen in patients with tracheoesophageal fistula. So just remember that the most common type of tracheoesophageal fistula is the type 3, in which there is proximal esophageal atresia with distal tracheoesophageal fistula. Right? Very good. So, patient presented with chest pain, vomiting. These are the NCCT head and barium swallow images. And within this NCCT head images, we can see that there are foci of air within the mediastinum. So this is your pneumomediastinum, which is seen, and on the barium swallow images we can see that there is leakage of barium into the chest. Leakage of barium into the chest can be seen. So this leakage of barium into the chest, it is due to the esophageal rupture, and this is a case of Boer-Haave syndrome. Boer-Haave syndrome, in which you are going to have a triad of chest pain, vomiting, and subcutaneous emphysema. So another very important a very important condition: a 6-week-old child presented to the emergency with non-bilious projectile vomiting. On ultrasound, the following observation was made. What do you suspect? So guys, the observation on ultrasound is that there is thickening of the pylorus. It is thickening is more than 4 mm in thickness, and it is extending for a length of more than 16 mm. Right, so this is a case of very good congenital hypertrophic pyloric stenosis. It is associated with paradoxical aciduria. So these are two patients complain of abdominal pain predominantly in the epigastrium. Barium meal was done. Barium meal is basically an investigation for stomach. On in the barium meal image we have two appearances. So in this image we can see that there is a Carmen meniscus sign. So, and in the first image we have the sign which is known as Hampton's hump. And Hampton's hump, just remember, this is seen in benign ulcer, and your Carmen meniscus sign is seen in malignant ulcer. Right? So another emergency condition, patient has abdominal pain, abdominal guarding rigidity is present. You get a chest x-ray erect of this patient, erect x-ray abdomen for this patient, okay, or you get a chest x-ray done for this patient. What are you able to see, guys? Okay, what are you able to see? PA view, chest is done, PA view, chest is done, or an erect x-ray abdomen is done. So guys, what are your imaging findings for this x-ray? What are your imaging findings for this x-ray? So on this x-ray we can see, anyone who wants to make a guess, or I can continue. Anyone, I will give you 1 minute to make a guess for this question. Come on, guys. Very good, Subhadeep. So here in this image we can see that there is collection of free air under the right dome of diaphragm, and this collection of air under this region is due to the perforation of the intestine, known as intestinal perforation. What will be the investigation? We will get a CECT abdomen done for these patients with a positive oral contrast, so that we can see what is the site of leakage in this patient. So other signs of pneumoperitoneum, named signs of pneumoperitoneum which you should know. The first is the football sign. Football sign. Second is collection of air under the central tendon of diaphragm, which is known as cupola sign. Third is you can see that the falciform ligament is visible in this image, and this is known as falciform ligament sign. Again, pneumoperitoneum, collection of air in the Morrison's pouch. This is known as Dodge's cap sign. And when the liver, sorry, this one is when both the walls, if you just look at the sign, look at this image very carefully, when both the outer and inner walls of the bubble loops are visible, this is known as Regular's sign. Regular's sign. And in the last image we can see that the liver edge is very beautifully visible, and this is known as liver edge sign. This is known as liver edge sign. Right? So now on this image we can see that there are multiple air fluid levels. Multiple air fluid levels can be seen in this image, right? And this multiple air fluid levels is seen in patient with intestinal obstruction. Now the question is, when do you call as bubble loops as dilated? So you have a 3-6-9 rule. When the small bubble loops are dilated by more than 3 cm, it is known as dilated small bubble loops. When the large bubble loops are dilated by more than 6 cm, large bubble loops are called as dilated. When the cecum is dilated by more than 9 cm, we call it as dilated. So this is your caliber of the various loops, and within the intestine you are going to see the small bubble pieces sign, so which is multiple foci of air. Normally what happens, the air, the contents of the bubble loop, they are mostly fluid, but when they become like feces, this is known as small bubble feces sign. Sir, normal MRI KT2. Okay, so Dr. Abhishek Shakya has asked how to look at the normal MRI. ठीक है, वैसे I have already discussed. I will just take 2 minutes to answer your question. ठीक है, so normal brain sequences. ठीक है, फिर से रिपीट कर देते हैं, नो प्रॉब्लम. देखो, ये हमने डिस्कस करे थे नॉर्मल एमआरआई ब्रेन सीक्वेंसेस. ठीक है, सो डॉक्टर अभिषेक, अगर आपको T2 वेडेड सीक्वेंस देखना है, द निमोनिक इज वेरी सिंपल, राइट? दैट इज World War II. Water appears white on T2 वेडेड images. So इस इमेज में just try to have a look at the CSF spaces. You can see that the CSF spaces, these are appearing bright, right? हाँ या ना? CSF स्पेसिस को देखो, ये ब्राइट दिख रही है, और यहाँ पे वेंट्रिकल का थोड़ा सा पार्ट दिख रहा है, ये भी ब्राइट है. जब CSF ब्राइट होगा देन यू हैव टू कॉल इट एज अ T2 वेडेड इमेजेस. ठीक है, अब जब बात आती है CSF डार्क, जब CSF डार्क होगा तो इमेजेस कैन बी You have to look at the white matter. This is the white matter. अगर white matter white है तो वो T1 mirrored image है. If white matter is white, it is a T1 mirrored image. If white matter is dark, ठीक है, white matter is dark, it is a flare image. ठीक है. और अगर आपको ड्यूरल साइनसिस एनहांसिंग मिल रहे हैं, जैसे ये भी एक T1 मिरर्ड इमेज है, ये भी T1 मिरर्ड इमेज है, ये भी T1 मिरर्ड इमेज है. तो व्हाट इज द डिफरेंस बिटवीन दीज टू T1 मिरर्ड इमेजेस? So in the second T1 mirrored image, there is enhancement of the dural sinuses. ठीक है. So this is a post contrast T1 weighted image. ठीक है. और अगर हम डिफ्यूजन वेटेड इमेजेस की बात करें, अगर हमें इमेज की क्वालिटी बहुत पुअर है, ठीक है, बाहर की बोन्स वगैरह नहीं दिख रही हैं अगर हमें, ठीक है, अगर बोन्स वगैरह नहीं दिख रही हैं तो वो डिफ्यूजन वेटेड इमेज है. सिंपल सा फंडा याद रखने, ठीक है. और अगर हमें काले काले धब्बे दिख रहे हैं, ठीक है, काले काले डॉट्स दिख रहे हैं, ब्लैक डॉट्स दिख रहे हैं, देन इट इज़ अ SWI इमेज. ठीक है. तो ब्रीफली मैंने बता दिया, और अगर नहीं समझ आया तो फिर से आप वीडियो पे शुरू में जा सकते हैं, ठीक है, आफ्टर द लेक्चर. तो हम आ जाते हैं एब्डोमिनल इमेजिंग पे. So now guys we had to अब हमने पता लगा लिया कि डायलेटेड लूप्स बोलना कैसे हैं. Now how to call it as small intestine obstruction or large intestine obstruction? If the dilated loops are seen within the central part of the abdominal cavity, then it is a small bowel obstruction. If dilated loops are seen within the peripheral part of the abdominal cavity, it is a large bowel obstruction, right? So this is how you can differentiate. Now this is another very important question, another very important triad. So here we can see that there is a stone which can be seen, okay, gallstone can be seen. Basically a stone can be seen that is resulting in obstruction of the small bowel loops. So there is a gallstone resulting in small bowel obstruction, and also we can see pneumobilia. So can you tell me what is the triad that you are able to see? Pneumobilia. Subhadeep, would like to make any guesses? Gallstone ileus, small bowel obstruction, pneumobilia. What is the name of the triad? So this is a very important triad which you guys should know. This is Rigler's triad. So earlier we studied Rigler's sign. Rigler's sign was seen in pneumoperitoneum, and Rigler's triad is seen in obstruction due to gallstone, right? Very important images. Single bubble sign seen in CHPS, double bubble sign seen in duodenal atresia, and triple bubble sign seen in jejunal atresia, right? Then you have this coffee bean shaped appearance of the bowel loops. This is seen in cecal and sigmoid volvulus. Cecal and sigmoid volvulus. When it is pointing towards the right upper quadrant, that is mostly due to the sigmoid volvulus. And you can also see that ostrations are absent. Ostrations are absent in the ostrations are absent in the sigmoid volvulus, whereas in cecal volvulus you can see ostrations are present, and it is pointing towards the left upper part of the abdominal cavity, right? Then you have the target appearance seen in patient with intussusception. What is intussusception? When one part of the bowel loops moves into the another, right? It results in the target appearance, and you can also see the claw sign on the barium enema images. Claw sign on barium enema images. These are all important signs of the intussusception. So you should know what is intussusceptum and intussuscipiens. So the part of the loop that is moving into another, it is intussusceptum, and the part of the bowel loop which is receiving the other bowel loop, it is intussuscipiens, right? Accordion signs in pseudomembranous colitis. Okay. Now talking about this comb shaped appearance of the vessels, right? Because of increased pericolonic vascularity. This is seen in Crohn's disease. In the second image, what you can see that there is narrowing of the terminal ileum. This narrowing of the terminal ileum, this is known as string sign. So this string sign of Cantor, this is seen in tuberculosis. This can be seen in Crohn's disease. And in the third image, we can see that there is loss of frustrations, and this loss of frustrations is seen in inflammatory bowel disease, that is your ulcerative colitis. And in the last image, we can see that there is thumb printing of the colon, that is seen in patients with ischemic colitis, right? Now talking about important signs that you are going to see in intestinal tuberculosis. Important signs. So the first sign is narrowing of the terminal ileum with gapping, right? This is known as a Fleschner sign or inverted umbrella sign. And in the second image, we can see that there is the shape of the IC junction is that of goose neck. Okay, so this is the goose neck deformity of tuberculosis. Another named sign is Stirling sign. And what is this Stirling sign? There is rapid emptying of the terminal ileum. Right? This is the case of acute appendicitis, and the outer wall to wall diameter is more than 6 mm. The patient presented with pain in the right iliac fossa. There was probe tenderness, and on the ultrasound, these are your following observations. So guys, this was about the important, barium meal images, barium swallow images, barium follow through images, important chest, important abdominal x-rays that you are going to see in gastrointestinal radiology, and I'm sure it is going to answer 90% of your questions. Now I'm going to begin with hepatobiliary images, which is a trend which is now being asked. MRCP images. We will just have a quick review of all the important tumors, right, in just 10 minutes. ठीक है, तो शुरू करते हैं. First is the central scar sign. Okay, here you can see that this is seen in patients with focal nodular hyperplasia and fibrolamellar variant of HCC. Then you have this double density sign. This is seen in a patient with liver abscess. And if you are seeing multiple conglomerate collections, this is most likely your pyogenic liver abscess. A solitary liver abscess is usually a amoebic liver abscess. You see an anechoic cystic lesion on the ultrasound image. Okay, that is most likely your hydatid cyst of liver or simple hepatic cyst, right? If you are getting this typical appearance, this is the water lily sign. This is again seen in patients with hydatid cyst. Now I'm going to talk about the most common benign tumor of the liver, that is your hemangioma. So in hemangioma, what do we study? We study that there is progressive enhancement of the lesion on various phases. So the first is the arterial phase image, arterial phase, because aorta is shining, and the other are the venous and the delayed phases, because you can see IVC and aorta are having a similar enhancement. So now guys, what is happening in these images? If you look at these images, there is progressive enhancement of the lesion, right? From the arterial to the delayed scans, there is progressive enhancement of the lesion. So this progressive enhancement of the lesion, this is seen in a patient with hemangioma, right? This is seen in a patient with hemangioma. And if you are able to see a lesion that is showing enhancement during the arterial phase, and washout during the venous phases, this is a typical feature of hepatocellular carcinoma. Typical feature of hepatocellular carcinoma, right? Now in these images, what we can see in these images, these are the ultrasound images of the abdomen, and we can see that this is your gallbladder, and within the gallbladder we can see there are echogenic foci which are showing posterior acoustic shadowing. So this posterior acoustic shadowing, this is seen in a patient with GB calculus, and if a similar echogenic lesion is seen that is not showing posterior acoustic shadowing, that is the case of gallbladder polyp, right? And this gallbladder calculi also gives a sign that is known as Mercedes Benz sign. And what you can see, okay, the gold standard investigation of choice is HIDA scan, and on the HIDA scan you can see that a normal gallbladder will show uptake on HIDA scan, whereas uptake will be absent on the HIDA scan in a patient with acute cholecystitis, right? सो फटाफट से MRCP images देख लेते हैं. What are MRCP images? ठीक है, MRCP images are just T2 weighted images of the abdomen. So what happens, your any fluid filled structure like your CBD and the intrahepatic biliary radicals, they are going to appear bright. ठीक है, तो इसमें क्या हो गया, CBD देखो, this is the CBD, this is the right hepatic duct, right, and this is your left hepatic duct. So you can see that all these are appearing bright, and within this hepatic duct what you can see that there is a black filling defect. So this filling defect is nothing, this is your calculus. So what we are able to see that this is a CBD stone which can be seen on this MRCP image, right? And on the second image we can see that this is the cystic duct, difficult to identify, but this is a cystic duct, and within the cystic duct there is a calculus in the distal end, and this cystic duct stone, it is compressing the common hepatic duct with resultant dilatation of the RHD, LHD and common hepatic duct. So this is a case of Mersey syndrome. Again, you are going to read this thing in surgery also. So just a recap. And in the third case, guys, we can see that there is saccular dilatation of the CHD. So this saccular dilatation of the CHD, this is seen in a patient with choledochal cyst, And what is the classification system that we use for choledochal cyst? Rodani classification. So type 1 is fusiform or cystic dilatation, right? Type 2 is a diverticulum which is arising. Type 3 is cystic dilatation of the distal cavity. Type Type 4A is intrahepatic, uh, intra as well as extrahepatic dilatation of the biliary radicals, right? And this is the type 5, where you can see that there is only intrahepatic cystic dilatation of the biliary radicals, and you are seeing cyst dot within a cyst sign, dot within a cyst sign, right? So this was about hepatobiliary images, right, in 5 minutes. I hope this is going to give you some insight. And if a question is asked from the hepatobiliary images, okay, I'm sure you will be the only one to answer it. Okay, so like in 10-20 minutes we are going to revise few important images from the section of MSK radiology, right? सो शुरू करते हैं. सो सबसे पहले तो बोन ट्यूमर्स, राइट. बोन ट्यूमर्स के बारे में एक बेसिक डिस्कशन, लेट अस डू इट. सो हाउ टू आइडेंटिफाई, व्हाट इज द प्रोटोकॉल सिस्टम दैट वी यूज टू आइडेंटिफाई बोन ट्यूमर्स? So the protocol system that we use is ELTA protocol. So guys, can you tell me what is this ELTA protocol? Anyone who can tell me what is this ELTA protocol? Anyone, what is this ELTA protocol? So guys, this ELTA protocol, so ELTA protocol, A stands for age of the patient. Okay, ELTA protocol, A stands for age of the patient. So there are few tumors which can be grouped according to the age. So there are few tumors which are common in less than 20 years of age, few tumors which are common between 20 to 40 years of age, and there are few tumors which are common in more than 40 years of age, right? So guys, can you tell me what are the tumors which are common in more than 40 years of age? So these are metastasis, chondrosarcoma, right, and multiple myeloma. Tumors which are common between 20 to 40 years of age, this includes your GCT, enchondroma, and perosteal osteosarcoma. Perosteal osteosarcoma. So basically, what is happening? Age of the patient is helping you classify the bone tumor, right? So this was about age. Then there are few tumors which are present at particular location. So tumors can be classified based on their location. Based on their location, they can be epiphyseal tumor, diaphyseal tumor, or a metaphyseal tumor. So guys, can you tell me what are the tumors? What are the tumors which are common in the epiphysis? This can be remembered with a simple mnemonic, that is your E, C and G, where C stands for chondroblastoma, G stands for giant cell tumor, right? And tumors common in the diaphysis can be remembered with the mnemonic coffee. C stands for cyst, O for osteoblastoma, F for fibrous dysplasia, E for Ewing sarcoma, and E for and chondroma. So these are the tumors that you can remember. T stands for transition zone and A stands for appearance. So we will see based on appearance, right? So guys, just look at this first X-ray. Okay, of all the images from the bone tumors, this is the most important image that you should remember. This is the most important image that you guys should remember, right? So guys, what are you able to see on this image? Anyone who can tell me what are you able to see on this image? Anyone, guys? So here in this image we can see that there is a cystic lesion which can be seen, that is seen within the epiphyseal location, right? Cystic lesion seen within the epiphyseal location. And you can see that the epiphyses are not fused. Okay, growth plate is not fused. So guys, this is a case of chondroblastoma. If the epiphyses would have been fused and the tumor would have been located within the epiphysis, this would have been a case of giant cell tumor, right? Now here in this image we can see that this is a onion peel type of periosteal reaction, and this onion peel type of periosteal reaction, this is seen in patients with Ewing's sarcoma, right? Now let us have a look at few other tumors. Okay, so here in this image we can see a lytic lesion involving the diaphysis of the humerus, and we can see a fallen bony fragment. So this is the fallen fragment sign. Of simple bone cyst, and in the second image, guys, what we can see that there is a lytic lesion involving the epiphysis of the bone, and you can see that the growth plates are fused. So this is your giant cell tumor. And in the third image we can see that there is a lytic lesion that is present within the cortex of the bone, and surrounding it we can see that there is thick periosteal surrounding reaction. Okay, periosteal reaction, and the patient will present with history of night pains. So this is a typical case of osteoid osteoma, right? Night pains that is resolved by taking NSAIDs. Right? So now there are tumors which are common in particular locations, and based on their locations you can also guess these tumors. So if a tumor is located within the clivus, okay, what are you going to think of, guys? Come on. Tumor located within the clivus of the bone. What is the bone tumor that you are going to think of? Okay, you are going to think of chordoma. They have physelliferous cells, right? If a bone tumor is present within the fingers, okay, you are going to think of enchondroma. Multiple enchondromas, just remember they are associated with Maffucci syndrome and Maffucci syndrome and Olliers disease, right? So soft tissue hemangiomas plus multiple enchondromas, these are associated with enchondroma. A tumor located within the tibia, you are going to think of adamantinoma. Adamantinoma, right? Now moving on to the other images. Based on the appearance, right? How can we classify tumors? So onion peel type of periosteal reaction we have already discussed. Ewing sarcoma, this is the sunray pattern of periosteal reaction. This is seen in osteosarcoma. Then you have this Codman's triangle. Codman's triangle, this is seen in again osteosarcoma, right? Osteosarcoma. Then this Shepherd-Crook deformity, again very frequently asked. Shepherd-Crook deformity seen in fibrous dysplasia which syndrome it is associated with, this can also be asked. Then you see a bony outgrowth from the adjacent to the knee joint, and it is growing, bony outgrowth can be seen from the bone, and you can see that the cortex of the parent bone is continuous with the cortex of the underlying bone. Okay, so the cortex of the tumor, it is continuous with the cortex of the underlying bone, and this is seen in a patient with osteochondroma. And you have this corduroy cloth appearance or polka dot sign. This is seen in a patient with hemangioma. And in the third image, again a lytic lesion involving the fingers. Right? Now blood fluid levels, right? Within a bone tumor. This can be seen in patients with giant cell tumor, osteoblastoma. Then you have aneurysmal bone cyst, and you have telangiectatic osteosarcoma. Right? Bone tumor present in the calcaneum. This is your calcaneal lipoma. ठीक है? Cockade sign will be seen. So most common primary tumor causing bone metastasis in males is lung carcinoma. In females it is breast carcinoma. Most common primary tumor causing lytic mets is lung, and most common primary bone tumor causing blastic mets is prostate carcinoma. Again, very important one-liners, right? So important imaging appearances in the metastasis, right? So we have this winking owl eye sign. We can see that one pedicle of the vertebra is absent. This is winking owl eye sign. Both the pedicles are absent. This is the blind vertebra. And in the third image, guys, we can see that there is lytic destruction of the cortex. This is your cookie bite mets associated with lung carcinoma. And in the third image, we can see blowout mets associated with RCC and thyroid carcinoma. Right? So now on this image, what we can see, guys. So these are the tumors which are common. So multiple lytic lesions can be seen within the skull, right? So this is seen in a patient with Multiple myeloma, it is associated with vertebra plana, right? Very good. And in the second image, guys, we can see a ring and arc shaped calcification, a ring and arc shaped calcification within a tumor that is involving the right pelvic bone, that is seen in a patient with chondrosarcoma. An isolated lytic lesion of the skull, isolated lytic lesion of the skull, this is seen in a patient with eosinophilic granuloma, right? So at last, let us discuss few important arthritis. Okay, few important arthritis. So first is inflammatory arthritis. So just remember that the inflammatory arthritis, it is associated with periarticular erosions. So here in this image we can see that this is your joint, and around the joint we can see that there is erosion. There is erosion of the bone. So periarticular erosions, this is a very important characteristic of rheumatoid arthritis. And two important deformities that is it is associated with is swan neck deformity and boutonniere deformity. Swan neck deformity and boutonniere deformity. ठीक है. अब ऐसे ही वन मोर इन्फ्लेमेटरी आर्थराइटिस दैट इज वेरी इंपॉर्टेंट, दैट इज योर एंकाइलोजिंग स्पॉन्डिलाइटिस. Patient will come with history of back pain. Okay, what you are going to see, you are going to see erosions at the end of the vertebra, and you can also see a shiny corner sign which is known as your Romanus lesion, right? You can see that there is squaring or barrel shaped vertebra which can be seen. You can see bamboo appearance of the spine, bamboo appearance of the spine, and you can see that there is calcification of the interspinous ligament resulting in dagger spine. Calcification of the interspinous ligament resulting in dagger spine, right? Mouse ears, right? Mouse ears, okay, they will be seen in your psoriatic arthritis. Psoriatic arthritis. Now if you see a patient has come with morning stiffness is present in rheumatoid arthritis, ठीक है. And if you see a patient coming with history of pain in the first metatarsophalangeal joint, you see that there are rat bite erosions of the first MTP, first metatarsophalangeal joint. You are going to think of gouty arthritis, right? Then talking about neuropathic joints can be seen in patients with diabetes mellitus, Tapes dorsalis, syphilis. Okay, the patient does not have sensations of his foot, right? Because of this there is consistent trauma to the joints, and because of this you can have this licked candy stick appearance, right? In which there is complete destruction of the phalanges, right? You can have disorganized joints, right? You can have there is destruction of the joint, there is dislocation of the joint. So all the D's can be found within the neuropathic joints, that is destruction of the joint, dislocation of the joint, debris within the joint, increase density of the joint, distension of the joint. So these are the few important D's that are seen within the neuropathic joints, right? So this is again a very important image. Calcification of the anterior longitudinal ligament. Calcification of the anterior longitudinal ligament is seen in diffuse idiopathic skeletal hyperostosis, more common in Japanese population. ठीक है. सो जल्दी से रिकेट्स भी रिवाइज कर लेते हैं. मेटाबॉलिक बोन डिजीजेस, रिकेट्स, ठीक है. व्हाट यू आर गोइंग टू सी, you are going to see widening, okay, widening, cupping and fraying of the metaphysis, right? You are going to see rachitic rosary, right? If I talk about vitamin C deficiency, that is scurvy. Okay, scurvy में क्या मिलेगा आपको? You are going to see Trummerfield zone of rarefaction, subperiosteal hemorrhages, Wimberger ring sign, and white line of Frankel. White line of Frankel, right? So last I want to discuss few important vertebra. Okay, that is your bullet shaped vertebra. Bullet shaped vertebra. Bullet shaped vertebra, short proximal limbs, champagne glass pelvis, and trident hand. Trident hand. These are important features of achondroplasia, right? Then talking about calcification of the epiphysis, stippled calcification of the epiphysis associated with warfarin use in female, right, is seen in patients with chondrodysplasia punctata. Chondrodysplasia punctata, right? Long fingers and aortic dissection. Long fingers, that is your arachnodactyly, and aortic dissection is associated with Marfan syndrome. ठीक है. And last, okay, we have a J-shaped sella and inferior beginning of the vertebra, that is seen in patients with Hurler syndrome. Hurler syndrome, right? Increased density of the bones, increase in the density of the bones with, and along with that, bone within a bone appearance. Bone within a bone appearance is seen in osteopetrosis. Osteopetrosis, right? आज के लिए इतना ही, ठीक है. So guys, this was all about important images of radiology. I hope that you like the session. So I would definitely want you guys to please let me know how did you like the lecture. Okay, you can also share an Instagram story about this lecture, and you can tag me, and you can tag pw underscore meded on our Instagram page. So this will help us keep us motivated and bring us more such lectures like this, right? So don't forget to tag pw meded, right? And if you like this revision session, and also do share it, this revision session with your friends, right? Do share it on your Telegram groups. And we are coming with more such revision sessions for other subjects also. Do subscribe to the channel to stay updated about it. And if you have any questions regarding your strategy, okay, you can ask me now. And after tagging us, okay, do let me know your do share it with your friends, okay? And you can also watch this video later on 2x. So this is approximately a 2-hour lecture. You can condense into 1 hour if you watch it in 2x, and it will definitely help you revise most of your radiology images, ठीक है? तो टैग करना मत भूलना, ठीक है? और शेयर करना मत भूलना, और चैनल तो आपने सब्सक्राइब कर ही लिया होगा, ठीक है? और कुछ पूछना है आपको, यू कैन आस्क मी, और यू कैन लीव इट ऑन द कमेंट सेक्शन, और यू कैन just message us, right? So till then guys, bye bye, take care, keep working hard, okay? And just keep on solving MCQs, keep on giving grand test, and keep on revising your content, right? Whatever notes that you have made, and I'm sure that you will pass your FMGE exam. Bye bye guys, take care, all the best.